So welcome everyone to today's Talking Point. I'd just like to start by acknowledging the traditional custodians on land on which we stand, the Wurundjeri people in the Kulin Nation, and pay respects to elders both past, present and emerging. And also I'd like to extend that respect to any Aboriginal and Torres Strait Islander peoples in the room today or online. I would also like to acknowledge the strength and resilience of the people we provide service for here at Turning Point and the contribution and lived experience that they have to our services. I'm Professor Dan Lubman. I'm Executive Clinical Director at Turning Point and also Professor of Addiction Studies at Monash University. I'd like to welcome you all to today's Talking Point series. October is Breast Cancer Awareness Month. It's the most commonly diagnosed cancer among Australian women. Turning Point hosts publicly accessible seminars called Talking Point on topics that aim to inspire, inform and challenge our notions of what we know about addiction and its impact on society. Today's Talking Point webinar focuses on breast cancer and alcohol and is a blended event with an audience here at Turning Point and an online audience. Our online audience can participate by answering questions in the Q&A function on the Zoom, and these will be answered by Jasmine, our speaker today, at the end of the presentation. The event is recorded and will be available to view on the Turning Point website, so please subscribe to our main list to be notified when this recording will be available. And obviously anyone who couldn't make today's event, please let them know that the event is available to them and will be available on our YouTube channel. Let me now start by introducing our speaker today, Dr. Jasmine Grigg. So Jasmine is a research fellow here at Monash and at Turning Point. She has expertise in clinical research methods and mixed methods implementation research. And her research focuses on women's health, novel public health interventions, and addictions treatment. Jasmine has been an investigator on and managed multiple clinical trials of novel behavioural and pharmacological interventions to improve addiction and health outcomes across patient and community populations, including the current NHMRC-funded nationwide ready-to-change intervention trials for alcohol and methamphetamine use disorders, and a Vic Health and Eastern Health Foundation co-funded world-first study of a brief intervention for women attending breast screening services, which we'll be hearing about today. So it gives me great pleasure to introduce Jasmine, who's going to talk about this world-first intervention, and I'm really pleased that we have in the audience today our co-investigators that Jasmine will introduce, and also our new philanthropic research partners. Again, Shades of Pink, who I'm really pleased could join us here today. So please introduce, my pleasure to introduce Jasmine today. Please welcome her.
Thank you, Dan. Thanks for the introduction, Dan. So good afternoon. Today I'm presenting some research that we've been working on since 2019 to understand whether alcohol brief interventions are needed in the breast screen setting, whether they're acceptable to women who attend these services, and whether they work to improve women's alcohol literacy and address harmful alcohol consumption. So I'd also like to start by acknowledging the traditional custodians of the land on which we meet today, the Wurundjeri people, and acknowledge the traditional custodians of the land from wherever you may be joining us online. I pay my respects to their elders, past and present, and I extend my respect to the Aboriginal and Torres Strait Islander peoples here today. I want to acknowledge the broader team that is behind this project for your expertise and contributions over these past few years. It's great to work with you. I'd also like to acknowledge our funding partners, Vic Health, the Eastern Health Foundation, and Shades of Pink, and our collaborating organisations as well, Monash University, Turning Point, Eastern Health, Breast Screen Victoria, and the Life Pool Project. And I'm delighted to present this work today as we observe Breast Cancer Awareness Month. The month of October provides an important opportunity to highlight one of the most critical health issues affecting women around the world, and also their families, friends, and caregivers. So for a bit of background, here's what we know. Breast cancer is the most prevalent cancer in Australia and globally, to echo what Dan said just now. There are more than 2 million new cases diagnosed and 685,000 deaths worldwide each year. And it's estimated that over 20,000 new cases will be diagnosed in Australia in 2022, and there will be more than 3,000 deaths. A woman's risk of developing breast cancer is due to a combination of non-modifiable and modifiable risk factors. While there are some factors that we cannot change, like family history and getting older, other factors can be modified to decrease risk. And there's now strong scientific evidence that alcohol is a major modifiable risk factor for breast cancer in women, with 4.5% of cases worldwide attributable to alcohol consumption. The proportion's even higher here in Australia, with nearly 6%, or 1 in 17 cases, being attributable to alcohol consumption. So let's take a moment to consider how much alcohol is in an Australian standard drink. Here in Australia, a standard drink refers to 10 grams of alcohol, which, for example, is about 100 mils of red wine, as you can see at the top image here. It's important to know that a serve of alcohol that you pour yourself at home or get at a bar or a restaurant usually contains more than one standard drink. For example, the average restaurant pour of red wine contains 1.6 standard drinks. And while there's a dose-response relationship between alcohol and breast cancer, in that the more alcohol consumed, the greater the risk, we now know that increased breast cancer risk is associated with lower consumption levels than those previously deemed safe, of as little as 0.6 to 1.3 standard drinks per day. Breast cancer is now recognised to be one of 7 cancers causally linked to alcohol consumption, even at very low levels, along with mouth, throat, esophageal, liver, and colorectal cancer. And also among women with a breast cancer history, drinking low amounts of alcohol can increase the risk of recurrence. However, population awareness of the alcohol breast cancer link has remained surprisingly low, including among mid to older age women who are a population at highest lifetime risk for developing this cancer. And while Australia's use of alcohol is declining, risky drinking, including daily drinking, has remained stable among women aged 40 years or more, and has even increased among some age groups, such as women aged 50 to 69 years. And the COVID pandemic has further increased some women's alcohol consumption. Even so, mid to older age women's drinking remains largely overlooked, and health information about the alcohol breast cancer link is not systematically provided. For example, a recent study looking at the experiences of women attending breast cancer screening and treatment settings in the UK, among women in this study, they commonly reported that not once did the subject of alcohol come up. So given all of this, we started to wonder how we could go about implementing an alcohol brief intervention in the breast screening setting. Alcohol brief interventions are short sessions where a few brief questions about a person's alcohol consumption are asked, followed by the provision of information and strategies to keep drinking in a low-risk range. While there's strong evidence for their effectiveness in improving alcohol literacy and reducing consumption when delivered in general practice settings, there have been multiple barriers to their implementation, such as GP time or lack of time. As a result, there's been a call for other health profession involvement in responding to harmful alcohol consumption in the population. Population-based breast screening programs are uniquely positioned to provide timely and targeted alcohol brief interventions. The screening appointment can act as a window of opportunity to increase engagement with breast cancer risk reduction information. And with 43 million women participating in screening each year in Australia, the US, and the UK alone, this setting has potential for extensive reach. So, we set out to confirm whether alcohol brief interventions implemented in this novel setting are needed, whether they're acceptable to women, and whether they work. For the first 2 studies that I'm about to present out of 3 today, just to give you a heads up, we use the applicable elements of the consolidated framework for implementation research to guide the identification of factors that can promote successful program implementation. With these studies, the first 2 studies, mostly focusing on the outer setting to identify the need for alcohol brief intervention among this population, intervention characteristics, particularly adaptable elements to improve implementation, as well as some features of the inner setting and the implementation process. So for the first study, we wanted to confirm whether the approach we were proposing was even needed in the first place. Our aim was to examine the prevalence of risky drinking among women among breast screening service consumers, according to the latest Australian alcohol guidelines. This was a retrospective analysis of cross-sectional data from Peter MacCallum Cancer Centre's Life Pool project, where we analysed the alcohol consumption data of more than 49,000 women who were mostly recruited through the statewide breast screen program, who were aged 40 years or more, living in Victoria, and had completed a Life Pool entry questionnaire. The LifePool entry questionnaire contains a series of demographic and health-related questions, and our study's been the first to examine the alcohol data of this large sample of women, which included quantity, frequency, and frequency of heavy drinking day variables. So let's take a moment to consider the latest national recommendations to reduce alcohol-related health risks. In response to the current evidence for harms associated with drinking alcohol, recommended consumption limits have been decreasing in Australia and in other parts of the world. In December 2020, the Australian National Health and Medical Research Council decreased the recommended limit for healthy adults from 2 standard drinks per week, which was effectively 14 standard drinks per week, to 10 standard drinks per week, and advised consumption of no more than 4 standard drinks on any one day. So women in our study, who were on average 60 years of age, results showed the majority had recently consumed alcohol. 1 in 5 were drinking at a level exceeding current national guidelines for weekly consumption, and 1 in 6 were exceeding guidelines for consumption on a single day, more than once per month. So overall, while women attending breast screening are typically considered a more health-conscious group, this study found risky drinking to be prevalent among this large sample, according to the latest national guidelines. These findings are concerning in light of the strong evidence that even very low alcohol consumption increases breast cancer risk, and make a strong argument that there is a need to address risky alcohol consumption among this population of women. So in the next phase of this research, we wanted to understand whether it's acceptable to offer information to women about alcohol to women attending breast screening. And we also wanted to understand how to implement an alcohol brief intervention in this setting in a discreet and non-stigmatizing way. So in 2020, we conducted a mixed methods study involving an online survey of 391 women who were breast screen service consumers. And we worked with an additional 31 women to collaboratively design the alcohol brief intervention to be tested in the following phase of the research. This time, members of the LifePool project were invited by an email circulated to randomly sampled groups of women to participate in the survey, a focus group, or a telephone interview. So we found that of the women surveyed, the 391 sample, that 9 out of 10 women reported recent alcohol consumption, which was slightly higher than what we found in the previous cohort. And a higher proportion, 1 in 4, were drinking above current national guidelines for weekly consumption, which, as we learned before, now recommend that healthy adults drink no more than 10 standard drinks per week. We also found that just 1 in 5 women accurately identified alcohol as a risk factor for breast cancer. In contrast, pretty much all women who responded to this survey identified family history as a risk factor, which shows a big discrepancy in this group's knowledge of evidence-based breast cancer risks. Women want to know, and they want BreastScreen to tell them. An impressive 97% of women surveyed supported adding a few minutes to their screening appointment in order to receive breast cancer risk reduction information, which wasn't seen to be intrusive, but instead to be a positive addition to the current service provided. Also, 95% of women considered breast cancer risk reduction information provided in this setting to be more credible than from other health professional sources, and that included GPs. Women participating in focus groups also supported the idea of receiving alcohol information while attending screening. For example, Linda said, "You're not just there to have a check, you're there to be educated at some level as well." And Jane said, "BreastScreen are the experts, that's why we go there." So through the focus groups and telephone interviews, women offered several ideas for the design of the alcohol brief intervention. They strongly endorsed the use of visual information, particularly video with audio, and we took this on board and worked with an animator to develop the intervention, some parts of which you can see here. They suggested providing the alcohol information alongside general lifestyle information to make the intervention relevant to all women, so that women who drink didn't feel singled out when they attended breast screening. And to achieve this, as you can see on the left, we included information on physical activity and keeping weight in a healthy range as other ways to reduce breast cancer risk. Women agreed with us that the messaging of the intervention should not be one of abstinence, but to be consistent with and increase women's awareness of the drinking limit recommended by current national guidelines, along with messaging such as the less you drink, the lower your risk of alcohol-related harm. However, women endorsed the use of impactful information still, rather than sugarcoating it, as one woman said, and also for alcohol behaviour change to be framed as a choice for women to make. So with these points in mind, and also to keep the alcohol brief intervention relevant to all women, so once again, we didn't have to single anyone out when they arrived at breast screening, we developed two versions of the intervention corresponding to drinking levels that exceed and do not exceed national guidelines. So for women drinking more than 10 standard drinks per week, we developed personalised messaging, as you can see in the top middle tile, informing them that they are drinking above the recommended limit, that 8 out of 10 women their age are drinking less alcohol, and that the amount they are drinking is putting their health at risk. And for women, that works. For women drinking 0 to 10 drinks per week, we developed alternative messaging, informing them that they are drinking within the recommended amount, that they are doing a good thing for their health, and that the less they choose to drink, the lower their risk of alcohol-related harm. As well as this personalised feedback based on drinking level, both versions of the alcohol brief intervention contained negatively framed messaging around alcohol-related risks and harms, positive framed messaging on the health benefits of reducing alcohol intake, and harm reduction strategies. So to sum up study 2, this study showed that offering breast cancer risk reduction information in the breast screening setting was perceived by women to be highly acceptable. This phase of the research also led to the development of the alcohol brief intervention, which we called Health for Her, with input from women to ensure its appropriateness for the breast screening setting. So in the most recent phase of the research, we sought to understand whether an alcohol brief intervention implemented in the breast screening setting, specifically Maroondah Breast Screen, works. We conducted a hybrid effectiveness implementation trial last year, where we tested the Health for Her intervention with 558 women at Maroondah Breast Screen. The study design we chose allowed for rigorous comparison of Health for Her against a control group receiving general lifestyle information only. And we also sought feedback about the intervention and its implementation from participants and staff, with program evaluation being guided by applicable elements of both the RE-AIM and the CFIR frameworks. Women attending the service for routine mammography were invited to take part in our study after their screening appointment. There was no time before the appointment because Maroondah Breast Screen were very efficient, so we decided to keep it at the end of the appointment. Women who agreed to participate were asked a few questions about their alcohol consumption by a researcher, that was Peter in the audience today, before being randomly allocated by the researcher to receive the Health for Her intervention or control to view on an iPad, and were followed up with a telephone assessment 4 weeks later. So of women in the study, 279 were randomised to the Health for Her intervention and 279 to the control. At baseline, average age was around 60 years. 82% had recently consumed alcohol, which was slightly lower than in the previous 2 studies we found. And just 1 in 5 had knowledge that alcohol consumption increases breast cancer risk, which was a similar rate to what we found in our survey. The proportion of participants completing a follow-up session was high at 93%, and a subset of women allocated to the Health for Her intervention participated in an additional telephone interview to provide program feedback. So for the primary outcome, knowledge of alcohol is a clear risk factor for breast cancer. We found that change over time in the proportion of participants accurately identifying alcohol as a clear risk factor for breast cancer was significantly greater in the intervention arm, represented by the red bars on the slide, relative to control. This finding was echoed in feedback from participants who had been allocated to the Health for Her intervention. For example, Cindy said, "I was surprised that alcohol was raised as a cause of breast cancer because I had assumed it was primarily genetic factors that led to someone developing breast cancer." And Laura said, "I didn't even realize that there was any link." We also found positive results for other alcohol literacy outcomes, where change in the proportion of participants accurately identifying A, the amount of alcohol in an Australian standard drink, B, the number of standard drinks in an average restaurant serve of red wine, and C, the maximum weekly consumption recommended by national guidelines, was significantly greater in the intervention arm, again represented by the red bars, relative to control. This finding was supported by participant feedback as well. For example, Nellie said, It's like, oh shit, okay, I'm actually having 6 drinks on an evening, not what I thought was my maximum of 4. And Cordelia said, hearing about the actual serving sizes made me more aware of how much I was drinking. For alcohol consumption outcomes, while changes over time were not significantly different between groups, some participants reported that they reduced their drinking as a direct result of the intervention. For example, Helena said, I moved from 3 alcohol-free days to 5 consecutive alcohol-free days, and I felt good about that. Adeline said, I now consciously have a few days in the week where I don't drink anything. And Lauren said, you know, maybe on a weekend, if I'd had 5 scotches, I might now have 3. So we found that the proportion of participants accurately identifying physical activity and keeping weight in a healthy range as other ways to reduce breast cancer risk significantly increased for both our intervention and our control arms, which both received the general lifestyle information. As Darcy described, so I've tried reducing alcohol and have been exercising more. Alma said, I was sort of thinking, do we really eat our fruit and veggies? And now I make sure we do. We also found that a significantly higher proportion of participants in the intervention arm reported that they shared the health information that they learned with others. Teresa said, I remember going home and speaking to my sister and told her I'd seen this video about the impact of alcohol and breast cancer. She hadn't known that. So this indicates that our messaging had reached beyond the participants of the trial and that this intervention was perhaps contributing to distributed health literacy. We also sought participant feedback about health information being received in this setting more generally. Some participants did report that the information about alcohol made them feel uncomfortable, mainly because it made them reflect on their own drinking habits. For example, Helena said, I know that my alcohol consumption is too high, so it was like a bit of a kick up the backside, really. And Alma said, you answer these questions, then actually you're drinking over the limit. And you realize they're not talking generally, they're talking specifically. So yeah, it was quite effective, but confronting. So still an overwhelming 99% of our trial participants reported that the health information that they received was acceptable, and 96% endorsed that it should be part of the standard service provided. 97% of the trial participants reported that the health information they received was trustworthy. As Vicky described, the affiliation with Breast Screen, the information was coming from a reputable source. And Bethany said, if something wasn't backed by proper research, I don't think it would have been allowed to be delivered in that setting. iPad acceptability. So 98% of trial participants reported that the provision of health information via iPad was acceptable, and 94% reported that they'd be comfortable receiving an iPad and headphones to participate in the intervention in the waiting room if it was implemented in practice. As Vera described, once I got used to it, using the iPad was okay. It was different to my iPad, but it worked out okay. And just on that, as an aside, the high rates of positive responses about the program may indicate the presence of social desirability, a limitation, which may be a study limitation, where socially desirable attitudes and feedback about the intervention may have been over-reported. However, program feedback was collected by a different researcher to Peter. It was collected by Chloe, who had no sort of personal interaction with participants, and was collected through telephone interviews, which are more robust to the effects of social desirability as they permit a sense of privacy and anonymity. So we also, as another part of the program evaluation, we also interviewed Maroondah Breast Screen staff about intervention implementation. Staff were highly supportive of the Health for Her intervention as part of routine care. For example, one manager said that with Health for Her, we're taking a client-focused approach. This is the kind of health information that women need to know, want to know, and it's something they can do something about. Another manager said, in both the design of the study and the way it was conducted, it was done very appropriately. And a receptionist said, the more women we can let know, down the track, it will start reducing breast cancer risk. However, staff indicated that there may be some challenges with implementation at other screening sites and reinforced the need for a self-completed version that does not require staff or researcher facilitation. For example, one radiographer described that some screening services don't have the space for a researcher to see the ladies after their appointment. You're going to have issues like that with some of the sites. And another radiographer said, we can get the module right so that there's minimal need for staff support and minimal disruption to workflow. So to sum up study 3, we're getting there. The Health for Her intervention implemented in the breast screening setting improved women's knowledge of alcohol as a breast cancer risk factor, improved alcohol literacy more broadly, and was acceptable to women. While breast screening service staff were highly supportive of Health for Her as part of routine care, some potential issues with implementation were identified, in particular the current requirement of researcher or staff facilitation. While further research is needed to examine the effectiveness of this type of intervention in reducing women's alcohol consumption, this study represents an initial step towards increasing alcohol literacy and addressing harmful consumption among this under-recognised high-risk population of women. So what are our next steps? So we've recently received support from Shades of Pink fundraisers to co-design an automated version of the Health for Her intervention with breast screening service consumers. Automation of this alcohol brief intervention so that it can be fully self-completed on a device such as an iPad provides a low-cost, labour and time-efficient approach that has potential to overcome some of the issues with implementation in busy healthcare environments. An important objective of this phase of the research will be to ensure that the automated intervention is straightforward and easy for women to engage with. And we'll also evaluate whether there's need to offer the information in multiple, including more traditional formats to maximise accessibility. So that's the work that we'll be completing next year. We then plan to test the automated Health for Her intervention in a powered trial for its effectiveness in reducing women's alcohol consumption. And this will be completed alongside a comprehensive program evaluation to understand the factors affecting future implementation in practice. So in conclusion, we found that alcohol brief interventions in the breast screening setting are needed, they are acceptable to women, and we provided preliminary evidence for their benefits. Expanding access to alcohol brief interventions in novel clinical settings with emphasis on previously under-recognised high-risk populations has the potential for substantial benefit. And finally, breast screening services are of particular relevance as a setting to offer this type of intervention, considering the increasing prevalence of mid to older age women's risky drinking and the strong evidence that even very low alcohol consumption increases breast cancer risk. Thank you, everyone.
Thanks so much, Jasmine. So we've got time, lots of time now for questions. So really fantastic study. Big thanks to our colleagues at Marooney Breastscreen, Darren and Michelle are here today, who can also take questions, I'm sure, around the reality of it all. Maybe I'll throw to you because I think before Jasmine goes, would you like to say something about sort of the project from your perspective in terms of doing this work at Marooney Breastscreen? And welcome to come up here. Yeah. So Darren is the medical director at the...
Director and chief radiologist.
Yeah, so do you want to give your perspective of this research and sort of, yeah, the need for it and your experiences of it?
All right, yeah, no, thanks, Darren. Thanks, Jasmine. I just want to say working with the Turning Point team was, it was actually a pleasure for us. I think we got the easy, and Peter and Chloe, pardon me, I think we got the easy bit of the whole study, but we were motivated because, as it was shown, that women have a distorted sense of their risk factors, their control over, their risks of breast cancer. You know, anecdotally, women would be saying, "Oh, well, I've got a family history, or it's this, or it's that," and had no idea that what they drink or how much they exercise or what their BMI is actually has a greater influence as they get older. And more importantly, that it's modifiable, that, you know, they have a choice. I can do something about this. So that's what motivated us to be involved. We weren't surprised that women wanted this information and this was a way to do it, but at least now we've got the evidence base. And we are really keen to continue to get to the point where you know, women can come for their screening mammogram. We'll hand them an iPad. They spend 5 minutes on that while we finish off, you know, doing our breast screen paperwork. And yeah, hopefully will be incorporated as a routine part of your breast screen experience. And also it should be scalable across any kind of, health point of care, point of contact. So, yeah.
Thanks,
Hopefully we
Darren.
can continue to collaborate.
Absolutely. Thank you.
Well, Darren, while you're here, I might have one more question and then Jasmine as well. So I'll just get in front of the camera. Sorry.
Right. Yes.
That's for our online audience. So I suppose my question to you, and then Jasmine can follow up as well, is I suppose why do we have to wait to now to tell women that alcohol is linked to breast cancer or in breast screening services? So what do you think? What do you think the background to that is, and why hasn't that been sort of part of routine care up to now?
Dan, you asked really early.
I said Jasmine on pod yesterday. You get corrected.
Look, I think even with, I work in a breast screen organisation. It's all about people's what hits their radar and their horizon. And I think it's really only, we've actually created the horizon for breast screen Victoria in a way. So we all kind of knew that, there are risk factors, but we've really brought the focus onto it.
Thanks.
And not before time.
Thanks. Jasmine, do you have any further comments around why we don't typically ask questions about alcohol?
Yeah, I think that the major meta-analyses, we've known that alcohol is a risk factor for a long time, but we're only just starting to understand how little alcohol is actually creating significant risk. So that information is just becoming more and more concrete. And I think there's also been, I guess, other information about the potential cardiovascular health benefits of drinking wine in later life and so forth, which is now research that's starting to be turned on its head. So I think there's just maybe mixed messages about the health benefits and the risks, but it's really clear from the research that we've done that, this work needs to be done.
Still keep you up here. One more question. Sorry, and so I think, as you said, I mean, we're talking about an area that is highly stigmatized. I think across healthcare settings, people feel uncomfortable asking questions about alcohol. Doctors are much more happy talking about bowel movements than they are around how much you drink. So there's a lot of work there for us to think about in terms of how we encourage people to ask those questions. I think one of the questions we got from the audience, which I think is really interesting, that I'll ask both the two of you. One of the reflections here is, seeing the increase in drinking amongst women aged 50 to 69. That also corresponds with the time of menopause. Mm-hmm. Is there any evidence, or what's the link do you think between increasing drinking and maybe coping with some symptoms that might relate to the menopause, such as sort of problem sleeping or other symptoms might come on? Do you have any reflections on that, or Jasmine?
Well, I don't have any evidence base, but I would have thought the two biggest contributors to increasing consumption in that age group is they've got the money to spend on alcohol. They're entering retirement, either as phased retirement or full retirement, as relatively young women with quite a long life expectancy. And it's kind of part of the Australian fabric that alcohol, it is part of our social fabric. It's very hard not to drink. And then if you may drink once a week, and then, it's twice a week, 3 times a week. My own family experience is my parents retired to the Gold Coast, God's waiting room. And they were minimal drinkers in Victoria. And, within 5 years on the Gold Coast, they were drinking every time and every dinner because they had nothing else to do and everyone else was drinking. So I think it's that kind of insidious mechanism. So you actually have to have knowledge to make your own choices and not to go down that pathway.
Thanks, Darren. Jasmine, do you have any
nothing
comments?
further to add, I agree.
I might just ask you, Jasmine, so you mentioned earlier in your presentation, and it's a question from the audience around seeing some increased drinking during COVID and the pandemic. Do you want to just expand on that a bit in terms of particularly around women's drinking?
Yeah, sure. So we know that drinking did increase in some vulnerable groups, not everybody during COVID, during the pandemic. And we know also there's been an increase in even alcohol-related deaths in some countries, I believe, including Australia. And in terms of women's drinking, I think having children at home, additional responsibility there, plus managing workloads, plus the stress of, what was a global pandemic. You can quite easily see how it might creep in, like another lockdown's announced, oh, let's have a drink tonight because that's happening. And so you can see it makes intuitive sense.
Thanks, Jasmine. We just got a couple of questions just around, and I think you talked about it in your talk, but just to reiterate, a couple of questions online around what is the risk level around drinking that we think is risky for breast cancer? Do you want to just reiterate that again?
Yeah, sure. So there's a couple of big studies that have come out, one in 2015 and one in 2018. The one in 2015 said that drinking as little as 1.25 standard drinks a day, so that's 12.5 grams of alcohol. It's not much. It's probably a lot less than what you get at, as I said earlier, at a restaurant, at a bar, or what you pour yourself at home. Having 1.25 standard drinks per day can increase risk of breast cancer by 23%. So that was a figure that came out in 2015. In 2018, another figure came out of drinking alcohol of as little as 0.6 standard drinks a day can increase risk of breast cancer. I can't remember the percentage there, but that's a very light consumption. And it's the only cancer to be associated in that meta-analysis with very light consumption levels.
Thanks, Jasmine. A question for both of you again. So we've got a question from the audience just around those challenges of implementing this type of intervention in mainstream breast screening settings, because obviously I think the centre you have is, has a range of, I suppose it's more spacious maybe than some other settings where breast screening services are delivered. So what do you think the challenges are, both of you, in terms of implementing this across mainstream, across all breast screening settings?
I think if we get the kind of
It's only this audience that can see
the next platform iteration correct, so that it really is just user driven without needing or minimal staff intervention. I would see that there's actually no blocker to its implementation in a breast screening session. Our experience was if we did it at the end of the breast screening episode, the staff were able to, the reception staff and the radiography staff were able to continue as normal. There was no interruption to their workflow, and women could then spend as much time as they wish after their appointment to do the intervention. I would think also, to exploit, if they wanted to continue, they can pick up, do a save and continue, pick it up later, or, through social media or whatever. So I think, it's a matter of exploiting all those electronic media possibilities.
Which we met with Monash University's Action Lab just this morning about that. So that's definitely the next steps. I think having women just truly designed in the design of the intervention is going to go way forward in sort of having us implemented in practice, and actually having women pick it up and use it in practice. I think also women attend breast screening every 2 years. So I think it's about sort of thinking about how we can evolve this model. So it's the same messaging, we can update it based on the latest evidence, but have this model evolve, have the information confirm the information that was presented last time, but grow and develop. So I think that's another practical way that we can actually truly implement this in practice.
Thanks, Jasmine. Another question that I think draws on your other work here. One of the questions we have here is, how do you encourage women that you know around you to reflect on their drinking, and where would they go for help?
Yes. So I have conversations with my friends. I think it's just women don't know. And so it's that initial block. Women aren't aware of the risks. So I guess I'm at that stage of the conversations with my friends and loved ones. But I know that my mum has stopped drinking. She's pretty much cut it out. She was, she'd have it on an odd occasion, and she's really proud of where she's gotten. So I think I'm making an impact in her life anyway. So.
And look, that's our experience as well. I mean, when we poll the staff about this pilot, they were unaware of their alcohol consumption as a risk factor. When they realised how important it is, they were like 100% committed to doing this study, because I think, as soon as women realise, well, there's something I can do about it. I mean, it's kind of, it's kind of, it's got its own energy then. So I would think that it's hard to think of a blocker when, certainly women are, breast screen staff are predominantly women, certainly women facing for when you have your screening mammogram. So, and what was nice also was women as staff supported women as clients, and they were very supportive of the positive message around a modifiable risk factor rather than any punitive message around, oh, you drink too much or whatever. So
yeah, that was important.
Thank you. So we've got a lot more online questions. I'm just aware that we haven't taken questions from the audience here. Has anyone got any clarifying questions here? While you're all thinking and ready to put your hand, I might just ask as well. So one of the questions got from the audience, and you might not be able to answer this, but they're just saying in the sample that we had, were we able to look at women from different backgrounds and look at whether women from particular backgrounds were drinking at different levels or their receptivity to the intervention?
Yeah, sure. Peter, did we collect information, CALD data? We did. We've got the data. I haven't had time to analyse it yet, but we have the data, so we'll be able to provide some feedback about that in due course.
Thanks, Jasmine. Anyone want to ask a question?
Thanks so much for that. I was just wondering, in a sort of futuristic world with personalised medicine, not that I'm an expert on it, so Dana, with sort of epigenetics and genetic testing to sort of create a risk profile, be possible to really target at-risk people.
You want to just repeat the question for people online?
Yeah, sure. So thanks for your question, Tony. So sort of asking about risk profiles and epigenetics. So I'm aware, and you may be able to also speak about this, Darren, but there are risk profile questionnaires about breast cancer risk and sort of models that are available. I've seen that in the literature. I think the 2 or 3 main ones that I've read had nothing about lifestyle and specifically nothing about alcohol that was used to kind of formulate a level of risk. I've seen one paper saying it's needed, but as far as I'm aware, but I'm not across that literature, so you may be able to speak more to that.
Yeah, Jasmine, absolutely. None of the risk stratified is, pardon me, really, they don't include alcohol. And I mean, now they're starting to include things like BMI and even things like your mammographic density, which is the degree of whiteness on your mammogram, which we know is a significant and independent risk factor. Only now are those things being, incorporated into the models. But I think watch this space with artificial intelligence. There'll be a lot more, not stratified, but it'll be becoming more and more personalised based on those kind of factors.
Thanks. Any other questions? Just while you're thinking. So another question online, which I think is a great point. They're saying that if we do go fully automated in breast screen settings, what happens if women have a question? Will we be training up breast screen staff if women have a question coming out in the intervention?
Yeah, so Darren, you may be able to speak more to this about what's possible, but I think that this all needs to be nutted out. As well as women wanting to ask questions. We can have information of where to go to get more information, but there'll be sort of perhaps tech glitches that may happen as well. We'll need, some resourcing around that, but we anticipate it to be minimal. We anticipate it to be simple, but absolutely, I think we currently have the direct line number of if women want more information to call this number. But so I guess we would just amplify that in terms of information options.
And I would think again with the next phase, with a larger number of women, we want to capture that kind of feedback,
yeah.
As if, particularly if they've got a clinical question or a medical question, what kind of categories are they? And therefore maybe that can be incorporated into the platform. If they have a question, they might be able to access a sub menu or we could certainly follow up with some kind of one-on-one. But yeah, we'll need to kind of tease all that out. We've had a small group with 500 women where, hopefully there were, next year, the target in the state of Victoria alone is there will be 280,000 women having their screening mammogram. So we need a platform that would kind of work for all of them.
So one other question we got online, I think you touched on it earlier. So I suppose the question is can you tell us a bit more about women's drinking more broadly, and has it increased over time? And what are some of the factors that do you think it's drive the increase in drinking and drinking harms amongst women?
Yeah, sure. So looking at population data over the last 10 years, we can see that as a general rule, population over the last 50 years, actually, there's data to suggest that Australia's population, the drinking level of the Australian population has declined steadily over the last 50 years, whereas this group of women aged 40 years or more has stayed stable. So their drinking has remained the same as it was however many years ago, and it has increased in some age groups, specifically the 50 to 69-year-olds. I think it's due to a range of individual factors, but as we've touched on before, I think retirement, we drink when we're stressed out, when we're sad, when we're celebrating, when we're happy. There are many reasons, and it's it's such a massive part of social life as well, and perhaps that's feeding into the behaviour.
Thanks, Jasmine. I think just to respond to that as well. I mean, I think obviously there's been a whole movement around the acceptability of drinking amongst women, and obviously the industry around developing alcoholic drinks that are, really targeting that population, and then a whole, I suppose, social movement around the culture of drinking. So we were talking before around how people didn't used to drink at home or drank in a particular, only particular settings or any particular sort of types of occasions, whereas now what we have is, a very sophisticated normalisation of drinking amongst women. So it's drinking in every setting, any interaction, any type of group gathering of women. Alcohol is obviously presented by the industry as something that is sort of the first thing you open when everyone gets there, is open that bottle of champers or a glass of rosé or white. And so it's that sort of normalisation of drinking, and then the accessibility of drinking everywhere. So everywhere you go, whether you go for a cinema, whether you go for a haircut, whether you go to a primary school function, alcohol is now so normalised that it's everywhere. And I think that's why we see this increasing harms in this group. And I think one of the questions we had, which speak to this, is, this type of intervention is probably the first time that women hear that alcohol is a risk factor, because we don't tend to see any of that messaging in mainstream media at all. We're sort of saturated with alcohol being a good thing, not a bad thing. One of the questions we had also is around sort of the availability of the programme for all breast screening services. So are there any plans to share this with other breast screening services, and how can we adopt this nationally, is a couple of questions.
Well, I certainly hope that we can scale this from Maroon to Breast Screen Victoria, and then to Breast Screen Australia, and then every breast screen in Europe particularly is a very similar model to what we have. Really, any country that has a population-based screening program, and whether it's kind of bowel or breast, I mean, you can look at whatever the disease is, what are the modifiable risk factors, and I'm sure this platform could be modified. But certainly, yeah, I would think let's roll it out in Victoria, get it right, then it would be scalable to Breast Screen Australia. I mean, I think that should be our goal, at least.
And I guess
I'll
further to
certainly
that,
advocate for it.
that's great, Darren. And to add to that, and it was something that you and I discussed quite a while ago, among women who are receiving a diagnosis of breast cancer, who are receiving breast cancer treatment, or who are in supportive care. These are women who are at greater risk of breast cancer recurrence if they continue to drink alcohol at sort of higher levels, and we know that some women do from the research. So I think it's not just about sort of implementing interventions like this in breast screening, like sort of early intervention, early detection programs, but also in breast cancer treatment settings as well.
Actually, yeah, thanks, Jasmine. That's a really good point, because like for our service, we're co-located in the Eastern Health Breast and Cancer Centre. So the other big group of women that come to our centre are women who are symptomatic, so they've had a breast lump and they'll go through a process, and also women who've got a diagnosis of breast cancer and who will be coming back on a very regular basis for surveillance. And a lot of those women probably don't appreciate that, even if they have minimal alcohol consumption, as women already having had a history of breast cancer, their alcohol consumption is a significant modifiable risk factor. So the other group we want, is for those women who come to the centre, to give them the iPad so they can, do the same process. So absolutely, really, it's anyone who comes to the Breast and Cancer Centre would have access to this kind of platform.
Right.
Jasmine, great talk. I've got a question about the people involved in the pilot. It's good to see changes in behaviour or increases in knowledge, but do you have any plans to follow that up further to see whether those positive changes are maintained over time?
The 558 women in the trial, that we sort of designed that study just to be a 4-week. We also had a 12-week follow-up, which I didn't go into today. So that's where that ends. We then also had program evaluation questions for all 558 women. So we got feedback about the intervention from everyone who participated in a follow-up assessment. And then we also did the qualitative component with, to sort of understand women's experiences of the intervention in a bit more detail with a subset of 30. So that's where we've left that sample. But there's definitely room for potentially longer follow-up. And I think particularly once we do a multi-site study, once we're automated and we're ready to roll, sort of at multiple locations, so we can be conducting a truly powered trial to detect change in alcohol consumption if we're able to achieve that. I think that there's definitely scope for longer term follow-up, like other alcohol brief intervention trials that sort of run 12 months.
Thanks, Jasmine. I think that the point that maybe you want to talk about is, were we powered in this trial to look at reducing alcohol consumption?
Sure, thanks, Dan. No, we were powered to detect change in knowledge. So, we think that that's the primary reason why we didn't see a change in consumption. It may be that knowledge wasn't able to change behaviour, and that's also something that we need to examine sort of in further studies with much greater proportions of women. I guess what's different with our study relative to alcohol brief intervention trials that are conducted in GP settings is only hazardous alcohol consumers are entered into trials in those settings. Whereas we didn't want to single out women who were drinking at hazardous levels to come along and participate in alcohol brief intervention. So we invited all women attending screening to participate. So like a smaller proportion of hazardous drinkers were in that sample and may have diluted the effects on any change in alcohol consumption.
Question here.
Do you think that this is quite broad, so I guess anyone could do this, but do you think there's like a lack of knowledge with health professionals about the risk, like oncologists and GPs, and how do you think that can be fixed? Is it at like med school, or can you do interventions now, or?
Could you just repeat the question as well?
Yeah, sure. So thanks, Rach. So Rach was asking about knowledge among health professionals and where training might occur, whether that sort of happens once people are qualified, or whether it happens as a medical graduate or as a health professional graduate. There is some research that's come out of the UK that suggested while population awareness, or while women's awareness of the alcohol breast cancer link was about 20%, health professionals at breast cancer and screening and treatment settings, their knowledge of alcohol, the alcohol breast cancer link, was only about 50%. So definitely higher than general population knowledge, but still not that high as what you might anticipate. And Darren, would you like to add anything further to that?
All I would add is that I think one of the challenges, not only for women, but also their health providers, is the overwhelming amount of information that is needed in a situation you've got a cancer diagnosis. And it's kind of prioritizing that knowledge and selecting the right moment to deliver that knowledge. So I think, for women who recently diagnosed with breast cancer, they've got so many other decisions and choices to make. It's probably not the right time to say to them, well, maybe you should drink less. But certainly when they've got through, their acute treatment and they're in that surveillance phase, that's the time to really focus on, your lifestyle is your most important thing, because women probably don't realise if you've had a diagnosis of breast cancer, you are then the woman most at risk of another breast cancer, more than any other group. So they're the women that need to focus on alcohol consumption, lifestyle, diet, BMI. So it's just kind of getting the timing right. But yeah, I think these kind of raising general awareness of alcohol as a risk factor will work in all the, whether you're a clinician or a client or an allied health professional.
So I think we're at time. So can I just get everyone to thank Darren for being here and all the support of the project, and Jasmine for
Thanks, Darren.
So for people online or anyone that missed this session, so as I said at the beginning, the Talking Point series are all on our YouTube channels. Please subscribe to the Talking Point series so you're aware of upcoming Talking Points, and you can rewatch any of the great Talking Points we've had over the last couple of years. So again, thanks for tuning in, and we look forward to seeing you again at the next Talking Point in a month's time.